to have consumables and some drugs that are related to
hello. Himesh there? Hello. Himesh sir?
Hello.
Yes.
Hello.
What's here?
Not visible.
Cái bên đó nhé.
Hello.
Yes, I'm here.
Hello. Is it not
Sorry,
able to
we are
hear?
trying to, yes, because of some technical issue, we got locked out. So again, I'm sharing the PPT, I think. Yes. PPT is visible?
Yes.
Yes.
Yes,
It's visible.
Sorry. Okay, now we would like to continue. Okay, thank you.
Okay. So sorry for a technical glitch. So back.
Yes, it's visible.
Okay. Okay. So sorry, give us a few minutes.
Done speaking.
It's okay? It's visible?
Yeah.
Yes.
Sorry, I think this is the slide we left with. So I think there is another thing that I just wanted to consciously ask all of you, because I have spoken about so many gadgets in the ICU, and sometimes it gives us an idea that modern day ICUs are about all high-tech gadgets and gizmos, right? So how many do you feel so? I'm just, Nanuka is running a poll on this. Please respond to it.
I think poll is visible to everyone.
Is the poll visible to all of you?
Poll is visible to everyone. Yes, yes.
Yes, yes, ma'am. Yes, ma'am. Visual.
Thank you, thank you. We are getting.
Yes, it is.
We'll see. Let it run and we'll get the next one.
We will wait for 30 more seconds. Like questions we have given here, like resources will be better utilized in addressing common public health problem at primary level.
Yeah, so this is one question that I think we discussed about earlier, but let's see what all of you think about it. It will be interesting.
We are not being able to choose the option. There's some issue with
Huh?
I think we are getting options. From
Okay, we are getting responses, but anyway, don't worry. If you are getting participation, you are able to participate, do participate. It's just for fun. So there is nothing about this one. Okay.
Thank you. So I think we will end our phone here.
Okay. So regarding setting up of ICUs, we find here that 54% feel that it translates into improvement in quality of acute care and improves outcome if combined with other aspects of in the community. So that means at least half of our participants feel that ICU could be useful potentially, but as rest of you feel that there is some skepticism, and rightly so. Therefore, ICU should not be indiscriminately set up in all places, and therefore you should plan properly going ahead for setting up an ICU. Please launch the next one. Next.
I have a suggestion, Himesh.
Yes, ma'am.
If this is not working well, then you just ask the participants to answer in the chat box. Yes, no, yes, no, YN, no. Then also you'll get a good, it'll be faster.
So we can do that. Yes.
Yeah.
Yeah, please, you can put how many of you can put in a chat box and see how many of you do feel that ICUs are all about high-tech gadgets and gizmos. Yeah, if you think yes, then put yes. If you think no, then put no. Yes, so we have all, as expected, we have a mixed type of response. Many of you saying that, yes, it's all about gadgets and gizmos, and some of you say it's probably not. So let me tell you that in ICU, it's not the equipment that is treating the patient, it's the team of the ICU that is treating the patient. So please don't think that ICUs are all about gadgets. These gadgets are there only to help you. If we look back into how ICU started, it started just by the observation that keeping patients together in one room, sick patients together in one room improves outcome. So that was from where the concept of ICU started, and it reached the stage where we are today. So therefore, gadgets are to help us, and ICUs doesn't equate. We should not equate ICUs to high-tech gadgets only. Next thing is in an ICU, you also will need a lot of ancillary staff and support services. So based on where your hospital is situated, and based on what are the services that are available to you. So all of these services may not be available to you in all of your hospitals, but wherever available, how are you going to make these services available to your pediatric ICU? You should think about that. Like you may need physiotherapists, you may need dietitian, you may need respiratory technicians to look after the equipments, radiographers, biomedical engineers, social workers, blood bank. So some of you need to keep these consideration, that these ancillary staff and support services need not be in the ICU. It can be in the hospital. Sometimes some of these can be in the city or town where you're available, like some lab services, but you need to plan that ahead of time, that if you require these kind of services, then how are you going to arrange for your patient? Okay, next, go to this one. Yeah. Next, another concept that you need to keep in mind while designing your ICUs, then level of care. So level of care is divided into two sides, like level 3 care and level 2 care. So level 3 care ICUs are like, you can say high-tech. Keep it like this. Level 3 cares are like, these are high-end ICUs.
I would like to disturb you. I will share a screen from this distance. Can you give me a second? Okay.
It's fine, I think, Nanuka. It's we'll go ahead like this.
It's okay. It's okay.
Yeah. Next slide, please. Yeah. So ICUs are high-end ICUs, and here we are talking about setting up ICUs in district hospital level. We are talking about level 2 ICUs, where more of it will be in high dependency. These ICUs may not have enough expertise and will require some lesser intensity cases in these ICUs to begin with. Next slide, please. Next slide, please. And another angle that we need to keep in mind is that sustaining services and quality improvement, because when we start, it will not be in our best of shape, and we must have an idea how to sustain our services, because we do not know when setting up this ICU, we are going to sustain this for how many months, how many years. So you need to keep that in your mind. So for that, we must convince ourselves that it's setting up of ICU is a continuous process. Somebody needs to take ownership of these ICUs and then liaison with the medical superintendent, the state administration. We need to demonstrate some leadership so that we can sustain these services. Then training and retraining of manpower should be important. Then there audit, where clinical as well as process audits needs to be there, and networking, like affiliation to societies, networking with your colleagues who could be working in this field, or attending conferences, attending webinars. That could also improve the training and your orientation of your that staff that will be working in your ICU. Next, please. Organization, ideally, in charge of this ICU should be a pediatrician who is trained or experienced in critical care. And there should be round-the-clock doctors that will be available. Most of these district hospital, I guess we will have to depend on medical officers. So, but these medical officers need to be trained with good airway skills, and preferably whenever they get opportunity should undergo training on pediatric advanced life support. Then nursing requirements, if they are very unstable patients, sometimes they need up to 2 nurses per bed. But normally in ventilated patients, you will need 1:1 ratio, and in other beds, you can have 1 nurse to 2 to 3 patients. Next, please. So that is all in my presentation. These 2 recommendations that I have taken most of my talk from, and we have also shared this link in the chat box, as well as we have shared in the WhatsApp group. So for more details and more the list of equipments and list of drugs that are required, you can refer to these things. And I think at this point, I'll stop here and I'll invite comments from our experts and will.
Sir, can we take the question session at the end of this presentations? Let Sumar sister first present, and after the presentations, after both the presentations.
Anukal, I think let's go with one by one. That will be better because we'll try to not take too much of time, but quickly, maybe another 3
Okay, sir.
minutes we'll
Yes,
discuss.
sir. Now I would like to request Dr. Rosina ma'am. Rosina ma'am is an assistant professor in the Department of Pediatrics. So I would like to request to moderate the question session. And I will also request a participant, can you please mute yourself if you are not speaking? And then you can either write in a chat box or you can unmute yourself and you can ask directly. So thank you so much. And I would like to request Rosina ma'am to moderate the questions. Over to you, ma'am.
Monica, even I have some problem opening up the chat box. If we really, I'll be really thankful if other hosts could ask it.
Ma'am, I will read the questions from here. Is it okay?
All right, okay.
Okay.
I welcome Dr. Rachna, Dr. Sumit Periwal, and Dr. Sanjeev sir. Thank you for agreeing to share this platform with us and be with us on this day. Please hear the question, Anuka.
Yes, one question is asked by Samila Begum. So at least some basic gadget we need to like monitor, syringe pump, etc.
I'll give this question to Dr. Rachna. Can you read the question?
Yeah, thank you, Rosina. Thank you, Himesh, and the entire team of NEGRIMS for inviting me here. First of all, I think before I answer the question, I must tell you that I'm very happy to see that the ICU that we established in 2007 is today training others to do the intensive care. So the first question which Himesh put up was, do we really need pediatric ICUs? And it is still disheartening to see that many of you feel that it's a waste of money or time or space. But remember one thing, that 40% of the population of the country is below the age of 18 years. When you can have critical care, cardiac services and adult ICUs for elderly people who are at the end of their lives, I'm not saying they're not important, but why not have the pediatric intensive care services for children who are the future of the country? So based on that, when I started that ICU in NEGRIMS, I had a lot of opposition and people, questioned why you need this, but see where it has landed today. The second thing is that you need dedicated space. So you should have a good design and dedicated space, which I think Himesh has already shown you. And if any of you have the opportunity, do visit the intensive care unit, pediatric intensive care unit at NEGRIMS, because you'll see it is located very close on the first floor. And you can easily bring up patients up from the emergency where most of these sick patients will come. And he has already shown you the design. The second issue is you need to have a separate pediatric facility, because when you look at adult ICUs, the way they manage their patients, a single person may have at least 4 or 5 antibiotics going on, which is not the thing that we do with children. So our way of managing patients are different and the drug doses are different. One thing which I think Himesh missed out was that you need a 24-hour electrical backup. So you need a UPS supply. So if any of you are planning to make any such facility in your district level hospitals, then the 24-hour backup is important. Not for all the electrical points which he has shown, but at least 50% of the electrical points must have a 24-hour backup. Because if you have a ventilator or a monitor or something, or an infusion pump, which do have the backup electricity, but then if the electricity goes off in our country, very erratic electricity, so you might need these points to be having a uninterrupted power supply. The question about the high-tech gadgets, yes, we do not need high-tech gadgets. In fact, I remember Himesh will also remember when we started off, we had just a few jumbo cylinders, though I must tell you they're very dangerous, because if they fall on you, you're not going to be alive. So we try to avoid jumbo cylinders, and the best way to do that is to have a central line piping system. Now, if your administration is planning to make an ICU, always insist on a central line gas pipeline, which can also be done by attaching, instead of having those jumbo cylinders inside your ICU. It occupies space, it is dangerous. You have these jumbo cylinders at a facility which is away, and from there you connect it to the central pipeline system, and from there you get the proper gas supply to your unit. Now, not only oxygen, I would say that you, since these are, I mean, I was a part of the Government of India document which prepared these guidelines for COVID-19 preparedness in children. And the main idea was that whatever facility we have now, it should be sustainable, it should remain there for children. We have ignored the children for a long time. So in this case, what you should always insist is, and Himesh, I'm requesting you also, since you will be at the forefront of this program, that if they are making ICUs, insist on a central line, and that too with oxygen, air, and suction. 3 things should be there. Otherwise, you know, it becomes quite cumbersome later on. We had just some ventilators, some monitors, and we had the manpower with us who worked very hard, and that is how we started off the entire intensive care unit at Negrin. So therefore, you do not need really high-tech. We did not have all those centrally, designed monitors and all that, but we still managed. And as Himesh has rightly said, that it's the person with the patient and the man behind the machine which is more important. So I think that should cover whatever you've asked me. If you want, I can give you some of the points which I've noted down from Himesh's talk. Should I finish it, Himesh?
Yes, ma'am. Please.
Yes, sir.
So one more thing was that nowadays, this whole thing, you know, of level of care is changing, because we are moving away from an invasive ventilation to more of a non-invasive ventilation. So non-invasive ventilation, many modes are available, like high flow nasal cannulas and CPAP and NIV and BiPAP. And these can be easily done in your district hospitals. The only thing is that you need to have the courage to have this facility started in your unit. And as Himesh has rightly said, that probably it will be the medical officers who will be running. But along with the medical officers, I must tell you, it is the nursing staff which is the backbone of any intensive care unit. And if the nurses are well trained and they are guided by the medical officers, it's a very easy job. Of course, Negrims can handhold these units. If you have a problem, call up Negrims as a central, resource center, and they can even give you telemedicine facility or even guide you patient to patient. So I think the issue is that you just take the right step to start these services. Thank you.
Thank you, ma'am.
Thank you so much, ma'am.
We can invite some comments from Dr. Periwal. Dr. Periwal? Yeah, please.
Thank you for inviting me to this talk. I'm extremely delighted, and Dr. Himesh, your talk was absolutely enriching. You have already mentioned most of the things that we need in an ICU. There are a few things that I want to add, especially if we are taking into consideration that we are preparing for the COVID wave. One thing that we have to understand is whatever guidelines that have been made, which say that this is the amount of infrastructure you need, or this is the amount of personnel you need for a pediatric ICU, but those are all guidelines made during non-COVID times. And the problem with that is currently we may procure a lot of equipment for COVID ICUs, what we built for PICU for COVID, but getting manpower will be the most difficult aspect, whether it is trained pediatricians or trained pediatricians who are trained in intensive care, or the nursing personnel, which is, as ma'am rightly said, they are the backbone of the system, because we call these units pediatric intensive care units. Earlier, it used to be ITUs, the intensive treatment unit. Now it has been changed to the term care, because care is what we are providing. There are 2-3 things that I want to add to your talk. One is like being from a place like Sikkim, like we always think about seismic safety, like your ICU should be seismic safe. All the equipment that you have or cabinets that are there, they should have latches which don't open up during the earthquake and everything falls off. So this always comes to mind, like when you are in a place like Northeast, where like, and especially in Sikkim, where this is an earthquake prone zone. Other thing that I want to say is that these temporary ICUs that are being created, in these temporary ICUs, there is a chance that there will be loose hanging wires. Temporary wires are created. And if suppose these temporary wires are present, this will be a hazard. So temporary wiring, we should take care that whenever we are designing an ICU, there should be no temporary wires or loose hanging wires anywhere. Because when you are like working in like rapidly during a child who has collapsed, you may like trip over these wires. This is something that we need to take care of. Another thing, especially in the Northeast, that we should take is our earthing or hospital earthings, electrical supply earthings are not very good. So we should always make sure that the earthing is very properly made, because we will have a lot of gadgets in these ICUs. So if there is any issue in the earthing, these gadgets will go haywire. Sometimes they may collapse or crash at any time. So earthing is one thing that whenever we are making an ICU, we should tell to our management that we want a perfect neutral to earth in the ICU, at least all the electrical supplies. Another thing, especially in pediatric ICUs, like that is the floor should be non-slippery. Even in adult ICUs, but especially in pediatric ICUs, the floor should be as non-slippery as possible. Other than this, I think that you have taken care of all the points and what kind of ICU we need to create. But again, one more thing, as ma'am said, that we should have courage to build up ICUs or do non-invasive ventilations, even in the district hospitals or even in smaller hospitals and nursing homes that are present in the periphery of this country. But one thing, like, because I've been working on assaults on doctor for a very long time, I believe that ICU facilities have not been built up in India because people are afraid. If someone is dead, a child dies, then there will be a lot of chaos and problem. It's better do not create ICU facilities. So we have to also ensure the safety of the medical staff is working in the ICU. This is what I wanted to add.
Yeah. So Dr. Pariwal, these were very pertinent comments, and I think our participants will take note of it. And as Madam was telling, we have all the intentions to handhold the centers that we practically can. We have set up a WhatsApp group of all the participants, so you can put your questions there also, and we'll try to address those questions. You can reach us directly also, and we are also reachable through eSanjeevani for telemedicine for the consultations for any of the things. So these are the options that we have, and you can reach us on our numbers, personal numbers also, as and when it is required. So we have all the intentions for doing that. Now I want to invite Dr. Sanjeev Devnath. Dr. Sanjeev is around, so he can probably share the challenges and learnings that he have learned while trying and set up an ICU in his center, as well as what he's seeing in Barak Valley. Dr. Sanjeev, please.
Yes. Good afternoon, everyone. Most of the points are nicely explained by Dr. Himesh, and Rasna Madam has pointed out how she has created the ICU in 2007, and which has now training others. We have a small ICU in our Silchar Medical College. The most common problem we face is the trained nurses. The nurses we train gets posted in some other areas. I think this will be an issue in most of the district hospitals. So we are continuously training them and retaining the new nurses. So what help us is, I would like to add this point, making charts of the medicines which are used and the procedure checklist in the walls of the ICUs. I think this can be added in the setup of an ICU. Make say rapid sequence intubation chart checklist, than yours any procedure checklist, and the proper setting up of the instruments and the resuscitation equipments. When we started our ICU long back, 4 or 5 years back, then when we try to intubate a child, most of the times you had to search for the your bag and mask or your your laryngoscope. So we overcome this problem by setting up the proper crash card. I think maintaining a proper crash card will solve those problems which I face in setting up the ICU in our SMCH. And one more thing, beginning or starting an ICU will take a lot of hard work. One of the doctor will have to own this ICU to set up all the things in proper place. I think apart from this, most of the things are covered.
Yeah, thank you, Dr. Sanjeev. Those were very pertinent comments. We, as a part of this one, actually, this is a first series of the where we are trying to address the cognitive skills mainly, but practical and psychomotor, some aspects of this one, we are trying to address in 2 contact sessions of 15 days each, that these ICUs in Meghalaya that they are planning to set, that team of nurses, medical officers and doctors would be coming to our ICU for 2 contact sessions of 15 days. And we are planning to address that. And in other states where the people from other states, if you are those who are attending, I think you should find a way which is the nearest pediatric intensive care that is available to you. You can at least visit those ICUs for some time and see how those ICUs work. So that would be very helpful, I guess. So I think without wasting much time, we will move on to the next talk. It is a very practical talk on housekeeping in pediatric ICU. Our Sister Sumar will be talking on it. I request the experts to stay back for the session.
Thank you. And the rest questions we will take at the end of the session. Thank you so much. Screen is visible?
Yes, visible.
Ma'am.
Okay, okay, give me some. Okay, okay. Slide is visible?
No.
Okay.
You need to close
Now,
this
ma'am?
window.
Yes.
Yeah, yeah.
Now, ma'am, it's okay?
Yes, yes.
Okay, thank you, ma'am. So now I'll hand over to sister for the next topic. Thank you. A very warm good afternoon to the experts present here, and the PICU pediatrics department, as well as all the participants present today. Thank you so much for listening and coming to participate in this training session. My name is Sumadiam Khashandi. I'm a nursing officer in pediatric ICU. I'll be talking today about pediatric PICU housekeeping and protocols. So mainly housekeeping is like a support system in the hospital. It does not only involve one department, mainly it's an interrelated department. And it's not only the responsibility of a single department or a single person for the housekeeping department. It is mainly the coordination of all these healthcare providers. So as you know, like in the foreign countries, they do have a separate department, like the sanitation department, or an outsourced kind of a system where the housekeeping is maintained. But in our setup, in our Indian setup, we don't have that much of a luxury. So mainly this housekeeping is mainly supervised or mainly look after by mainly the nursing department. So in order to mainly continue, as I have discussed about the layouts of a pediatric ICU. So how do we sustain, or how do we continue the facility to provide care for the patient is mainly through the housekeeping department. So let us see, mainly the objectives are mainly to attain a high standard of cleanliness and general upkeeps, to ensure the safety of not only the patient as well as the staff who are working in the pediatric unit, and mainly to control and issue of cleaning and materials as well as equipment in order to prevent infection in the hospital, and to maintain the official reports of staffing and cleaning materials. Next, we will see at the components. So the components of housekeeping can be of various types, but then today I'll be just discussing about only these few selected components, that is the appealing interior design, storage and ergonomics, inventory, sanitation and cleanliness, hospital infection control and proper waste disposal, pests and rodent controls. So when we're talking about appealing interior and design, it doesn't mean that we should have the luxury of having all the good interiors or this one. It can be made from an improvised workout or an improvised plan. But as long as we have a clean setup,
a smooth working environment, as well as things that are arranged like your cupboards or your crash trolley that are arranged in a very systematic way so that it is accessible at the time of need. We do not have to run around, like sir have said earlier, that mainly for intending articles that are needed, especially in emergency, as well as arranging these articles in an area where it is accessible to at the time of need. And then it should be of a visual control system, and the appealing interior and the design should also have be able to motivate the employee to work. And the workstation of the area should also be spacious. Next component is mainly the storage and the ergonomics. When we say ergonomics, it is mainly the science of mainly to a setup of science that mainly the physical, the psychological, and the physical setup where it will bring a better output in a workspace. So when we talk about storage, we can lean on the 5 methods, the 5S methodology. This methodology was invented in Japan, and then it is mainly used for the better work output. So these 5 principles consist of, as you can see in the slide, the sort, systematize, shine, sanitize, and self-discipline. So if we follow these 5 principles, we can easily the workplace can be easily managed and maintained, as well as it will have a smooth functioning. Next, we have the inventory. The inventory forms a very important part in the functioning of any health setup, especially in the pediatric ICU. Inventory, we need us to have an inventory system or an inventory management, because why? So that we are always stocked for the emergency. We have the things that we are needed, like the consumable and the non-consumable. All these kind of inventory. And then inventory does not, it can be an official inventory or an unofficial. Official inventory, like your gadgets, your medical equipments, and your non-official is like your linens, your disinfectants. All these things falls under the inventory. And for your inventory, it is mainly the senior nursing officer or the sister in charge who is to look after all these. She is the one who has to chart down or list, perform a checklist of what are the things that are being used in the pediatric ICU, which things are used more frequently, which things are used less frequently. And then inventory system can also be classified. It can be classified in a form of a system like the first in, first out system. That means the things that we get first, that should be used first, and then later on the things that we are used later, so that there's no lapse. There's no lapse in using the medicine, and then it might end up in the expiry date. And then we can use the red tag system, means which one is we are using more frequently. So that is about the inventory. Next, about the hospital acquired infection. As you all will be having a better idea of what are hospital acquired infection. So let me just discuss, these are the various types: the bloodstream infection, urinary tract infection, pneumonia, surgical site infection, and gastrointestinal infection. So these infections are present in a hospital, and mainly it's because of unsanitary or there is a lapse in the infection prevention control practices. So how do we prevent all these hospital acquired infection? We have to have a better infection control practices. Hand hygiene should always be emphasized and always be reminded, and staff should be trained and reminded frequently for hand hygiene. For example, in our pediatric ICU, we have a signage of hand hygiene according to WHO, where we wash our hands and then hand rub for how many this one. So all those posters can be pasted so that everyone is reminded of hand hygiene. Then isolation and cohorting. This is very important, as because in a pediatric ICU, in order to prevent cross-infection, if it is possible in a pediatric setup, we can we can keep a patient with the same disease. We can keep them together. Like for example, in our pediatric ward, we have one cubicle where we keep only the COPS patient. So that is also a type of cohorting. And then how on improving infection prevention and control targets, we can have the care bundles, that is the CLAPSI bundles. All these things can be implemented in the ICU. And then other than that, there can be other innovative ideas where we can add up to how to prevent hospital-acquired infection. Next, we'll talk about the proper waste disposal. Proper waste disposal, I think everyone here, they are aware of what is biomedical waste. So biomedical waste, as you know, it's a solid waste generated from the hospital, either in diagnosing, treating, or treatment of or research or production of biological products. So according to the WHO, as you know, as you see in the slide, 85% of the hospital waste is non-hazardous, 10% only are infectious, 5% are non-infectious. So as a healthcare provider working in a hospital, we should be aware of how to segregate this biomedical waste, how is it collected, right to the time till it is transported to the area where it is being recycled or is being disposed of. So as you know, we have the color coding system for the various bins, for the biomedical waste management, and these are mainly referred to as by the Biomedical Waste Management and Handling Rule of 1998, as well as in with reference with the Pollution Control Board. So as you are all aware about the yellow bin, the red bin, the white, and the blue. I will not be discussing. You can refer it again. Next we have is the cleaning and sanitation. This is a very important component of housekeeping, as because maximum of if the cleaning and sanitation practices are controlled properly, so we are preventing a lot of infection in our ICU. So mainly it contains of the standardized cleaning protocols, the hand hygiene, the use of personal protective equipments when indicated, as in case of spillage, in case of any infectious disease, and all this. So what is the principles? Mainly we have to learn about the principle in order to make the cleaning procedures or the sanitary or the disinfecting procedure a very smooth and easy one. So we have to stick to certain principles, like we have to maintain a top to bottom approach always. We should clean from the cleaner side, then approach to the less clean area. Like suppose in an ICU, the doctor's room should be cleaned first. Then after that we approach to the ward. Then last it should be the restroom or the toiletries should be cleaned in the last. And then the other principles that we should keep in mind is that the heavily soiled area should be preceded with a careful approach in order not to prevent contamination to the other side. Stains should always be removed as soon as possible. And after cleaning, all the equipment should be washed, disinfected, and then kept up in proper places. So before we go to this one, we'll just see like right now we don't use sweeping with brooms. We don't use brooms anymore, as because it dispenses a lot of dirt. We use this microfiber mops, which are attracting to the dust as well as to the particles, so that they don't dispense more. These are called the micro mops, and these mops can the mops can be easily detachable and can be disinfected after use. So regarding floor mopping, we always use a 3-bucket system. As you know, the 3-bucket system is used in various ways in order to understand a kind of work system. So the 3-bucket system in the floor mopping is mainly, it contains of one is the detergent or the soap that is for cleaning. One is a clean bucket of water for rinsing, and the disinfectant bucket for disinfecting or sanitizing the floors. I hope you can understand regarding the 3-bucket system. So what are the various type of disinfectant that we use in our healthcare settings? So as this is these disinfectants are I've taken from the Kayakalp booklet, also known as a Clean Hospital Guidelines. So these are the various type of disinfectant, like this alcohol 70 to 90%, chlorine, either sodium hypochlorite or calcium hypochlorite, also known as bleach, phenolics, quartz or your ammonium compound quaternary, and iodophos. These are the various type of disinfectants that we can use for disinfecting as well as sanitizing the unit. So let us see what are the to what percentage can be used. We will not go into details about what percentage. You'll be getting all these in your handout, as well as your this will be this one. You can see. I'll just mention only a few. Like you can see, glutaraldehyde. If you want to be used as a sterilant, you have to use a dilution of more than 2.4%, and the exposure time or the stay time should always be more than 10 hours for about 20 to 35 degrees centigrade. Your hydrogen peroxide 7.5% for 6 hours at a rate of 20 degrees centigrade. And then for your disinfectant, we have your high-level disinfectant, intermediate, as well as low disinfectant. For your high-level disinfectant, we use a glutaraldehyde of more than 2%, 5 minutes stay time. Then your hydrogen peroxide 7.5%, 30 minutes stay time. And your hypochlorite, we have a 650 or 6 to 675 parts per million for 10 minutes. Then for your intermediate disinfectant, we can use your isopropyl alcohol, that is 70 to 90% for 1 to 10 minutes. And then your sodium hypochlorite, also we can use up to 10 to 100 parts per 1000 parts per million for 30 to 5 minutes. And then for your low-level disinfectant, again, we can use isopropyl alcohols. Since isopropyl alcohol is easily available and a cheaper type of disinfectant, it is easily used in our hospital setup. And then the stay time is more than 1 minute. As you can see, there's other types of disinfectants. So suppose if we are like, as you know that we don't get alcohol or isopropyl in that 70 to 90%. We always get either a 95 or a 92% concentration. So how do we calculate? Or sometimes we have to use sodium hypochlorite. The stock available in hand is 5%, but we need to use a 1% percentage. So how do we calculate? So we can calculate this formula, that is C1V1 is equal to C2V2, where C1 is a concentration in the stock, C2 is a concentration required, the volume of both the amount that is required as well as volume in hand. So if you can use this formula for calculating sodium hypochlorite, can anyone solve it, please? If you can solve using that formula. Okay. So let us just see, sodium hypochlorite 5% we have in hand, so we need to use it as a 1%. So how much under volume in hand? We have 100 ml. So after doing the calculation, we are getting that 20 ml. So 20 ml of 5% hypochlorite should be mixed with an 80 ml to make a total volume of 100 ml, so that we get a 1% of sodium hypochlorite. So this disinfectant can be used for your floor moppings and all this. Next, we have another type of disinfectant is your effervescent chloride, also known as sodium hypochlorite tablet. It is also available in a manufactured brand name known as Bacta-Free 1000. So this instruction you can also get in that container from the manufacturing company. They have already neatly presented in the container itself. But if for blood spill, we use 1000 parts per million, that is 1 tablet in 200 ml of water, and so on. So even for dishcloths or mopping cloths, after mopping, after dusting, we have to disinfect them. So what concentration should we use? 1 tab in a 35 ml of water. And then the concentration of both sodium hypochlorite or bleaching, that is calcium hypochlorite. As you can see, we have the concentration that is commercially available in a 5% or a 10%. You can easily calculate in a 1% concentration and with this kind of a formula. Then we have other type, that is your Virkon powder. I think you're familiar with Virkon powder or potassium monopersulfate. It's a high level disinfectant, and it's used for disinfecting hard surfaces like floor, walls, tabletops, equipments, patient trolleys, and patient beds. So the preparation is a 1% solution where we have to take is 1 spoon, that is, it has 10 grams in 1 liter. So you get a 1% solution. So these can use for your mopping. So the other type of solution, since your sodium hypochlorite and your Virkon can cause rusting or even staining. So if it's available, we can use Saniscope or Sanisquat. These are all type of ammonium-based disinfectant, and we can use these type of products, and the concentration on how to dilute is clearly mentioned in the bottle that comes from the company. And next is, as you know, that the items that harbors microorganisms are your bed frames, your bed linens, blood pressure machines, dustbin, keyboards, pouch, all these, like we can classify them as high touch or low touch area. So these are and then how do we disinfect them? We have to clean and regularly remove visible soil. The moment you see there is a soiling, we have to remove it immediately to reduce microbial burden. We have to use disinfectant such as quaternary ammonium or chlorine compounds. Then one thing we always have to remember in a pediatric ICU or nursery, we should not be using phenolics, as it can cause, it is known to cause, through some studies, to cause hyperbilirubinemia. And this hexachloroquine that is present in your Dettol and your triclocerin, these are associated with neurotoxicity. So we should avoid using these type of disinfectants in the pediatric ICU setup, as well as in nurseries. Humidifiers should always be drained every 24 hours, clean and refilled. Then toys should be used. Toys that cannot be adequately cleaned should not be used. Then then next we'll talk about a spill. It's about body or fluid spill. So the moment there's a spill in the ward or a department, there should always cordon the area by placing a wet flow signage. Then the person who's attending to the spill should be put in proper PPE, pick up sharp objects with forceps, and cover the area with paper and pour hypochlorite solution, that is 1% hypochlorite solution. Allow it to act for 10 to 20 minutes of contact time, then clean up, dispose, disinfect, and wash hands, as well as we have to disinfect the equipments that are being used. And the other types of prevention that we can use in order to prevent hospital-acquired infection is to reinforce hand hygiene. And as you know, in any ICU, everyone should have a bare below the elbows, and then no rings, no jewelries, nails should be cut short. All these things should be this one. Hand hygiene promotion program, like a few months back, in our NAGRIMS, we had our World Hand Hygiene Day. So it was a kind of motivation for all the ICU staff, who can perform the best hand hygiene program. So, and it's a good news to say that our pediatric ICU received the 3rd prize in the hand hygiene program. Yeah, we'll do better next time. And then we have to address the attitude and behavior of health workers. This thing can be done through, if we monitor, and then we are finding some health workers not adhering to like hand hygiene protocols. We can always address them and then motivate them to perform better hand hygiene. So hand hygiene in the pediatric ICU should not be encouraged only to the health workers, but also to the families and the visitors before they enter into the pediatric ICU or touching the patient. And then for hand hygiene, we can always keep these posters, like I have mentioned earlier, the 5 moments of hand hygiene: before touching the patient, before cleaning, before a clean or aseptic procedure, after contact with fluid or exposure, after touching the patient, and after touching the patient's surrounding. These can be put in area where everyone can see and they will remember. So next we'll discuss about how to use hand rub and to effectively reduce the growth of organism, as well as reduce hospital-acquired infection. So as you know, hand rub means we always have to use an alcohol-based hand rub. And there are about 8 steps that we use, and it takes only 20 to 30 seconds to effectively use a hand rub. And whereas for hand hygiene, that is using of a soap-based solution with water, under running water, that takes you about 40 to 60 seconds. And then wearing of adequate PPE. So your PPE, it depends upon what type of exposure or you're going to have, or what type of you're going to have approach. Then pest control. For pest control, as you know, maximum of the infection is carried by pests like rodents or like rodents and cockroaches. So pest control can be managed by the housekeeping department, like timely or during terminal disinfecting of a cubicle or a unit. The pest control department can always be called upon for disinfecting or the pest control. And then there are other ways that you can control pests is using for LED lights. These are more safe, they are more economical, and they help, they prevent the presence of pests around the ICU. Even in our pediatric ICU, we have an LED light for the control of mosquitoes and flies. And then before we go this one, so I'll just like to review. So the various components of housekeeping I've talked about is we have the appealing interior and design. And the second part is we have talked about the inventory. Then we have talked about the infection, hospital-acquired infection and control. Then we have talked about the storage and ergonomics. Then we have talked about the pest and rodent control. So I hope this is clear enough. So let's see how does housekeeping department, what is the outcome of the housekeeping department? So we get a better patient satisfaction, prevention of infection and control, enhance public relation, reduce the average length of stay, and it's also reduced in the cost of medical care. Then for the sign, I think it's easily you would understand what are the signs. I will not be going into details. And how to establish a good housekeeping program. So there should be a careful planning right from the beginning. That means the ICU should be easy to clean. A cleanup schedule or policy, like you have, like we have mentioned the 3-bucket system, those type of policies, or the disinfectant ratio. Then effective inspection, like almost all the hospitals, they have the kayak inspection. So those type of inspection are very helpful in maintaining the effective the housekeeping department. Then continuous supervision and enforcement of housekeeping rules that can also be done. And other than that, like we've mentioned earlier, you can include other kind of evidence-based practices like your care bundles. In order to prevent hospital infection. So thank you. That's about my presentation. In case you have any questions.
Thank you, Sister Sumar. That was quite an elaborate presentation. So yeah, for all those who are probably not working in ICUs as of now, that might be quite a mouthful for you. But don't worry, we don't expect you to remember all of that. If you have got the concept that so much goes behind the background when you are taking care of the patient, so that is important. We have shared the link of the National Hospital Infection Prevention Policy, and as well as the Kayakalp document in the group, as well as I think Nanuka has shared in the chat box. If Nanuka, if you have not posted, please post the links in the chat box as well. So you can download this document, print it out, go through it, and discuss that in your team, so that you can come up with a policy that is suitable for your institute. So with this, we're running short of time. I would request our expert to go through, give a quick comment. I'll start from Dr. Rachna to pick it, and then after the series of comment, then I'll go through the chat box and ask those questions. Rachna, ma'am, please.
Yeah, I think the most important thing is to remember that your ICU management should be like the way you manage your house. So that's why it is known as housekeeping. The second important thing is that these are best managed if you have protocols which are in place. In fact, the entire pediatric ICU management, whether it is clinical or the housekeeping, is absolutely protocol based. So once you have the protocol, everyone knows what to do when the patient comes and how to manage. So I think those are very important. One thing which Sumer, I think, didn't mention, but as a practical point of view, we like to restrict the number of people who come into the pediatric ICU or any ICU for that matter. So the best way to do is have some policies in place. Like if you want to enter, you'll have to gown yourself, you'll have to wear, open your shoes or remove your socks, wash your hands, wear a cap. So when you do all this, 50% of the time you'll find that most of the people would not like to enter the pediatric ICU, which is good enough for us. The second thing, because in pediatric ICUs, we have the attendants, we allow at least one person, preferably the mother, to be in and around. So that person should have a gown wearing when she is entering and staying with the patient, and she should also be doing the hand washing properly. I think that is all from my side, because the one comment is there that whatever she has shown could be really a little bit stressful on the eyes and your brain. But I'm sure when you come for the practical classes to Negrims, you will find that it's not very difficult. And my suggestion is to use chemicals which you are comfortable with, which you have always been using. So it doesn't mean that if my institute is using one kind of chemical, it is the best. You can always use things which are easily available to you. And I think I remember in 2006, we started the Model Injection Center program in Meghalaya. And we did a lot of these trainings, and people really adapted it according to the availability in the CHC and the PHC. So I think this is possible. Thank you.
Yeah, thank you, madam. Dr. Periwal, a quick comment.
It was a very nice talk, very beautifully explained all the chemicals and how housekeeping is to be done. In this, I would like to add one thing, which we did it at, like when I was in BCRO Hospital, Kolkata, which is like overburdened hospital, and like you have a lot of patients coming in, you cannot manage all the housekeeping. So we have one advantage in pediatrics, that we will have a mother or a parent or a guardian always with the baby. So we can take the help of the parent also in managing the housekeeping, that is keeping the area around the baby clean. So we should incorporate that is also in our protocols, that we will be taking help from the parent as well. As ma'am had rightly said that we have to it was also said that we have to hand hygiene and everything has to be not only for the doctors or the nurses, but also to the parents. But here we can take help from the parent, that at least the area around the baby and the bed and everything of the baby, because we are looking at a scenario where our manpower is going to be very restricted. So we can take help from the parents. So, and we can make a protocol that what we can teach a parent, whoever is getting admitted, that when you are with the baby, what are the things you will have to take care of. And like for hand hygiene, bed hygiene, cleaning the bed, keeping the surroundings clean, like coming in and going, you have to wash your hands, as well as you have to instruct others also. So we can take them and not as just as a parent, we can make them as a caregiver within our facility. This we had done in BCRO Hospital and it worked wonders. Like we had reduced the sepsis rate and like antibiotic use rate a lot by using mothers as the people who are taking care of the aseptic protocols. So this case, one thing that like, because when you are looking at a scenario, if COVID rises or third wave as it is so called, if it comes in, we will need as many hands as possible in keeping the housekeeping protocols alive in the hospital. Only our housekeeping staff or nurses will not be able to do it. So we will need more hands, and we can include parents in that.
Thank you, Dr. Periwal. Yeah, so we know the principles now, and then with whatever resources that is available, because hospital to hospital resources would be available, but keeping the principles of dignity of patients and family in mind, they will not mind to help whenever there is a scarcity. I think we can individualize on this level. Yeah, Dr. Sanjeev Devnath. Dr. Sanjeev is
yes,
around.
Yes, I am here. Yeah, almost all the things are covered so nicely, and but I have also noted down the points raised by Rasna Madam and Dr. Periwal also, because in our SMCH also we are taking the help of mothers and all at times other guardians. And what we do, we allow them enter the ICU, and I ask them to wear gown, and we provide them cards for entry, so that the other attendants cannot go and every time they come inside. So this can be incorporated. Only one attendant is allowed for a sick patient. So other things, I think all should be taken care of. Thank you.
Okay, so I think.
So Himesh, I wanted to add one more point.
Please.
That whenever we do the hand washing properly, we follow the 6 steps and all that. But then when it comes to using the towel, what happens is that you'll have one towel hanging there and everybody uses it. So how did we solve it in Negrims when we first started the PICU? We got people to donate their old newspapers, cut them into sizes which were equal to towels. And then we got them sterilized and used to keep it in a container, sterilized container. And whenever we used to hand wash, the staff would take it out with Jittle's forceps and hand it over to us. Sometimes it becomes a little cumbersome because you get the black ink on your hands, but that is one way you can economize on and also prevent infection. What I have done in my unit now is that we have bought small towels which are reusable, and once it is used, we send it to the CSSD for sterilization. So it comes in a seal pack. So whenever we wash hands, that is opened and given to us. So the advantage is that you can reuse and you're not harming the environment too much. So this can be done. I think in all your areas, please don't keep a towel hanging, or don't. Some units keep the toilet paper there, but I think if you don't sterilize it and you keep it like that, the entire purpose of hand washing is lost. And that is the only way you can have a unit which does not cause infections. And that is the major difference between adult units and pediatric units. If you do your hand hygiene properly, use less antibiotics, there are hardly any infections which occur. Thanks.
Thank you, ma'am. We are still using that newspaper thing still, which is going on. We have also got a hand dryer. So whoever prefers what we are going by that, ma'am. So that's a very handy thing to have. So I think that is all. I see only one question on this one on the 3-bucket system and spill. So Sister Sumar will be replying it on chat box. And because it will need a lot of time to be explained, or sister, you want to quickly tell them? Quickly maybe explain it, that will be.
Regarding the mercury spill, as you know, nowadays we have been, we have reduced the use of thermometers that contain mercury. We're using digital thermometers as well as digital BP instruments. So I didn't find it important to discuss about mercury spill because, as you know, housekeeping is a large topic. So anyway, if there's a spill, you can always use the kit. Since we always have the kit, you have to cordon the same thing. You have to cordon the area, then inform the sanitation department who has to handle the mercury spill. And then we also have a salt that we can pour in order to prevent it from oxidizing. That is your sodium thio. And sodium thiosulfate salt. And then regarding another question regarding the 3-bucket system, the 3-bucket system, whichever I've mentioned here, I've taken from the National Disease and Control guidelines. That is, it was given to you. There it is clearly written to use a 3-bucket system. One is the clean water, the second is the detergent water, and the third is your disinfectant. So we have to use a 3-bucket system, and we should not use two buckets for plain water. There should be one is for cleaning, sanitizing, as well as for rinsing. That is the 3-bucket system rule. I hope I'm clear. Thank you.
I think we will.
One more question.
Yes.
There was one more question. This is from one of the doctors in the district hospital that we're going to set up an PICU. So the question is, how can we make our PICU sustainable, especially in the government setup?
See, first of all, I think I'll take that question. First of all, we need to decide whether it's going to be sustainable or not. And I feel, and as Dr. Sanjeev was also pointing out, the first step in making that thing is the ownership. So whether the pediatrician who is there in the district hospital or team of doctors who are there in the district hospital, whether they take ownership of this PICU, whether they want to make it work or not. So if you decide that we are going to run it properly, and you have an ownership of things, then you have to take other people into confidence, change the mood in the hospital, including you have to keep administrators into confidence and try to mobilize resources. Arrange for training, you yourself also get trained, and you arrange for training of nurses, training of your medical officers. I understand that there will be a lot of problems, but all hospitals, problems of all the hospitals will be different, and it will be individual, and that needs to be handled properly. But first thing I believe is the will and ownership of the pediatrician in the hospital to run a pediatric ICU. Madam, you want to add anything on this, Prashna?
Actually, very valid question, but I will tell you that if you're in the government sector versus the private sector, since now I'm working in a private sector, it is much more easy to build and sustain an pediatric ICU, or for that matter, any ICU in the government sector, because you don't have to worry about the funds, you don't have to worry about people paying it to you. And as Himesh has said, it's only the ownership that is important. The second thing which you need to do is, now I have shared with you all, I think you will be getting the document about the Government of India guidelines, operational guidelines for COVID-19 preparedness in children. And if you see the document, it is very simple. It just tells you that we are going to build systems which are going to be permanent in place. So this is not like a temporary thing which the Government of India wants you people to do. It's a permanent facility which should be available for children. I don't know how many of you remember, but in 2008, we had a huge pandemic, or rather epidemic in Meghalaya, the meningococcal meningitis epidemic. We do not want such epidemics to recur. And at that time, also a lot of children and people died. So just COVID itself is not the issue. This could be anything happening in the next few years. So for any such incident, we want the facility for children to be as good as that for adults. So that is the reason why these systems have been put in place, why the operational guidelines have come, and the reason why you're having this training today. So it is sustainable. Only thing is that as a medical officer in charge of that particular district hospital or the pediatric unit or the pediatric ICU, you must have few things in mind at the beginning of each budget session. You must find out what are the things which are lacking in your ICU, what are the things, new things you want to add based on previous experience, make a budget for that, make an inline budget, and submit it before the 31st of March, so that all these are included in the budget expenditure of the next next budget year, and this will be budgeted by the Government of Meghalaya for your units. So I think this part is also, this administrative part is very, very important. And as I think Himesh had shown in one of his slides, auditing, that auditing is not only clinical auditing, it is also auditing of your equipments, of what you lack and what you need. So that includes right from the major big equipments up to the smallest cannula or syringe that you're using in your ICU. So if you do this properly, I think many of you will be knowing it much better as medical officers than me. So I think this is how you sustain. There are some units which are private-public partnerships. In those, what happens, the payment is taken, a small amount of payment is taken for investigations, for some of the facilities that are provided. And that is how they maintain or sustain a unit. But probably in the government setup, we would not like to have such a unit. I don't know, in Negrims, Himesh, we are asking people for payment now, because when I was there, that was absolutely free service.
Yeah, ma'am, we are charging some payment. Government mandates us to raise around 30% of total fund spent in Negrims. We have still not reached that, but ICUs, they have all ICUs, we have they need to pay 500 rupees per day.
Yeah, so I think that's a very nominal amount compared to what someone pays in the private sector. At least in my unit, the per day expenditure comes up to 5,000 to 7,000, depending on what facility the patient is being offered. So 500, 200, 300 is not a big amount. If required, that kind of a work plan can also be done, but of course, based on what the Government of Meghalaya wants. So I think it is sustainable, and you must encourage these to be done, because Meghalaya has a lot of conditions which require children to come to the pediatric ICU. And Himesh, how many patients are you having per year in your unit? About
I think, ma'am, we have close to 600-700 children in ICU, I think, per year.
Per year. So which
Yes.
is, I remember when we were there and it was the epidemic of meningococcal, and then you have so much of pneumonias and all that. We reached somewhere around 800 to 900 admissions per year at a particular point of time. So anything which unit which caters to about that much of patient, I think it's a good unit. And even in your peripheral hospitals, just giving a simple oxygen can also be what your ICU can do on managing this, the stage before shock. So I think we must all have these ICUs, and you people should come forward and do it. If we could do it in 2006-07, you can do it more easily now. Thank you.
Okay, thank you, ma'am. So I think we have come to the end of the today's session. I think we understand that there are some technical glitches, time management issues, and the number of slots that were available for login was slightly. So we will. This was a first session, so we will address all those issues. And I would request all of you to, all of the participants to join in our future schedule is made available to you. So please log in on time on those days. And we have tried to understand we have tried to address very common issues that you will be relevant to you if you are running a ICU later. So, please remember that you need to attend 80% of total sessions to be eligible for a certificate for the whole program. So 80% of all the topics or all the sessions that we are planning. So with these few words, I thank all the experts, all the people, all the participants, and I hand over to Nanuka for the closing remarks.
Sir, we have 5 more minutes. If any participants wanted to ask questions, unmute yourself and we can take up your questions.
There was one very important question from Dr. Diamond. He says, no autoclave here, any other means to sterilize the newspapers. So what you do is you take, maybe buy a big pressure cooker, use a closed tiffin box or some closed container, put the newspapers there, put it inside the pressure cooker with a little bit of water and pressurize it 2-3 times. They will be sterilized for use. I hope that solves your problem, Dr. Diamond.
Thank you, ma'am. Thank you, ma'am. Thank you. Any other questions? Any participant, you can unmute yourself.
And just to add one more point, say suppose that newspaper thing doesn't work out for you, just do not keep that towel that madam was mentioning, don't keep that hanging. You can air dry your hands, right? So don't use anything, you wash your hands and then you can air dry your hands, and it will take a little bit of more time, but at least you will not be carrying bacteria to your patients.
Thank you, sir. Any more questions? Yes, thank you. I think I have not seen any more questions in our chat box. Yes, Dr. Himesh sir correctly said, sorry, we are regret to say that today because of some technical glitches, we are not able to accommodate all, but I will make sure in next sessions, I will allow all of you to get in our session. So for that, I will really say sorry. And I think I have not seen any more questions in the chat box. So I think once again, I would like to thank Dr. Rasna ma'am, Dr. Sumit sir, and Dr. Sanjay sir. So thank you really, ma'am, your experience, your then point which you have shared. I think because in this participant, our whole Northeast team, they have joined. And I think it's really a practical based answers or practical based experience which we have shared today. And I think it will really help these Northeast participants. So once again, I would like to say thank you, ma'am. Thank you, sir. And
Anuka, I think what you need to tell these people is that the pediatric ICU in Negrims was the first pediatric intensive care unit in the entire Northeast only for children in the government sector. I'm not talking about the private sector. So if we could do it, they also can do it.
Yes, ma'am. Thank you, ma'am. Thank you. Okay. So again, I would also like to thank you, Himesh sir. So first, this is presenting the sessions in so practical way. It's not in the base of academic, it's on the basis of that current scenario, and on the basis of district level, we try to make the presentation as practical and possible. So thank you, Himesh sir. And I would also like to thank you, nursing officer, Sister Sumar, for explaining the presentation in very detailed and in a very simple way. So thank you, sister. And at the last but not the least, I would like to thank you all the participants who have consistently there till the end of the sessions. So thank you once again, because it's your interest and because it's your learning to your interest to learn new things, which is helping keeping our presenter also motivated. So once again, I would like to thank you everyone. Thank you.
Thank you so much, ma'am.
Thank you. I think we will end the session now. We will see you on Wednesday once again. So same link will be there. We are not changing the link. Please open the next session with the same link. We will accommodate all of you. Thank you once again. Or if there will be any changes, I will let you know in the group. And in the WhatsApp group, I have shared my number, WhatsApp number. I would like to request all the participants to directly ping me so that I can directly add you in that group. And we don't have a post-test here. We will give you the pre-test, and in between we will do the poll so that you will be whatever we are this things knowledge you are getting, you will get it on the time. So I think, thank you. Himesh sir, at any closing point you want to say, or should I end the session?
I think that is all. Yeah, I thank all of you from my team, and especially the experts for making all the time. And it was really a lot of value addition from all of you. Thank you so much.
Thank you. Thank you.
Thank you very much.
Very good.
And also regarding the PPT and the resource material, I'll share you in the WhatsApp group, okay?
Nanuka has shared her number in the chat box. So all of you who wants to be added to the group, please take her number. It's added here.
Just now also I have shared my number in the chat box. Okay, please directly ping me. Thank you.
Start video later. I would we'll go to direct question or what? Just give the question you want to finish like that. But because
Finish. Nyalakan bal mencah ini akan bal push push